Hello, everyone. My name is Abdulelah Alhawsawi. I'll be moderating this session from the World Sepsis Congress. I want to say good morning, good afternoon, and good evening to all the audience throughout the world. The session that we're about to hear is called Bridging Sepsis Knowledge Gaps in High-Income Countries and Low-Middle-Income Countries. First of all, I would like to thank our sponsors for actually helping us realize this session. And with that in place, I am going to actually introduce our first speaker, Dr. Andrew Argent. So Andrew has worked in critical care in Cape Town for over 30 years and directed Africa's largest pediatric intensive care unit until 2019. He's the chair of the African Sepsis Alliance and past president of the World Federation of Pediatric Intensive and Critical Care Societies. Although retired, he remains involved in the development of clinical approaches to the recognition and management of sepsis in children. He has particular interest in the provision of care to critically ill children in countries across the world and has been involved in the development and implementation of training programs for healthcare workers in pediatric critical care. Andrew continues to be involved in consultations regarding multiple aspects of care of the critically ill children. So Dr. Argent, the floor is yours. At the end of the speech of Dr. Argent, we will have some time for Q&A. So go ahead, Dr. Argent.
Well, thank you very much. And it's a great honor to be invited to speak at this meeting. So huge thanks to the organizers. I've been asked to address the issue of improving outcomes from pediatric sepsis. And clearly, this audience knows that sepsis is a huge cause of both mortality and morbidity. And that's across the world, but the brunt of that burden is borne by the poorer and lower resource settings of the world. And I want to highlight a little bit of those settings. A huge emphasis of what we do needs to be on the prevention of sepsis, but then we also need to deal with the acute illness. And then for me, a huge obsession is this idea that if we take children out of environments that have made them sick and set them up to have sepsis, we do all sorts of wonderful therapeutic things and then send them straight back into the same environment that got them sick in the first place. We're just going to maintain that cycle and throw away a lot of the work that has been done. And so I think there's a real need to focus on where are the high-risk situations, where are the situations where we can actually change things. Now, of course, as I've highlighted, sepsis across the world has a huge range. There are different populations in terms of age distributions, backgrounds of things like nutrition, exposure to HIV and factors like that. And then also, as we move across the world, the pathogens change. There are parts of the world where things like dengue, malaria are huge causes of sepsis. There are other parts, such as where I live, where those aren't an issue. And then, of course, the epidemiology changes from season to season, which vectors are available, and also what the population is there. We need to think of sepsis not just as a one-off episode, but as something that happens over a period of time. And it's my belief that very few patients present from complete health going to sepsis very acutely. For most of them, there is a prodrome. There's a period of days, often weeks, sometimes months, that precedes the acute illness. And then finally, there are huge differences in resources that are available. And we need to be sure that if we're going to treat children with sepsis, the right resources are available at the right time. This data comes from work published by Scott Watson and others. And I think, first of all, it highlights the way where the burden of disease sits with children. You can see that the under fives some years ago had something like 3 million deaths. But there were also 17 million survivors, and those survivors do not get away scot-free. And we need to consider the deaths, but we also need to think about what happens to those survivors. And what you can see is that the age group from 5 to 19 has a much lower burden of morbidity and mortality. but still a significant one. And one of my concerns is that this group of adolescents are one of the groups that are most poorly served by health systems across the world. You can see on the right here that the causative organisms for sepsis in low middle income countries and high income countries are hugely different. But a lot of the organisms that you see in this list on the left are those that are amenable to public health interventions, where we need to be looking at preventing nosocomial infection, and where there are lots of interventions that can actually be done to prevent these happening. On the same paper, we start out with this perception of what the progression is of sepsis, of a baseline which may or may not have morbidity, the episode of sepsis. Some patients may have premature death, and we know for children that something like 50% of the deaths related to an acute sepsis episode happen after hospital discharge. But what we need to think about more and more, what happens to all the patients with the partial recoveries, and what are the impacts on them, on their families, on the societies that they live in, and how do we deal with them, particularly in societies where long-term care is often extremely limited. And so those are some of the burdens that we need to address. If we think broadly of preventing sepsis, there's the high-risk groups here on the left, and there's the whole set of sociodemographic factors that actually are related to the development of sepsis, together with issues of access to healthcare. And sadly, the biggest burden of sepsis happens among poorer people, among children, and among those with poor access to healthcare. As a highlight of that, I just want you to look at some of this data on neonatal sepsis and infection death rate in infants. This is data running through from 1980 to 2021. What you can see is that in high-income countries, the infection death rate is low. It's somewhere probably around 30 per 100,000 infants. By contrast, in Africa, we have a death rate that is probably close to 350 deaths per 100,000 infants. It's orders of magnitude higher, and there's a huge opportunity for us to intervene in this group and actually make things better, both in terms of acute mortality and in terms of long-term outcomes. A recent paper by Angela Dmowski and others highlighted why those children get the sepsis, and it's related to a lot of issues around health or hospital-acquired infection. Some of the infections come from transmission from their mothers, but a huge burden of that disease in neonates comes from poor infection control. And so relatively simple measures of, but utterly focused and obsessive care about limiting nosocomial infection can have a profound effect on this. We do, of course, have to focus also on the diagnostics and how do we make sure that we pick up the infections and identify them correctly, and then also make sure that we deal with this burgeoning problem, antimicrobial resistance. Some other issues that I'd like to highlight on the left is data looking at projected under 5 mortality rates. But what they've done is that they've used subnational models here. And what you can see is that on the right, there's the national mortality rates, and you can see there are regions of high mortality. What we need to be doing is focusing on these incredibly dark areas here, which are much smaller parts of the whole group, where there's very high rates of mortality, and sepsis is the major contributor here. So one is collect the data and focus on regions that actually have those. One of the big concerns for me in Africa is the issue of displaced population and refugee camps. And here's a set of data, a systematic review, showing that on average, something like 40% of patients among these refugee camps have malaria. And in some of those camps, as many as 80 have malaria. And so refugee camps and displaced peoples are an area where we really need to throw focus at how do we limit the spread of infection and how do we deal with it. One of the other things that is related to infection, and I've deliberately chosen some data on tuberculosis because in the rich world, we forget about TB as a cause of sepsis, but it's an important cause across the poorer parts of the world. And here's some fascinating data showing that actually, if you were to provide some baskets of food to patients with tuberculosis, to their contacts, and to all their contacts and family members, you get hugely different percentages of prevented infections. And so simple measures like providing small baskets of food to the people directly affected may have profound effects on the incidence of sepsis, such as tuberculosis. What I also think we need to look at, and this is some data from the Phoenix study, is if you look at a whole data set of something like 3 million patients presenting to emergency departments in hospitals, what we see is that if you look at children with suspected infection in the first 24 hours, the mortality in high income settings is about 0.7%, whereas in low resource settings, it's up to nearly 4%. If you meet sepsis criteria, it's 7% in high resource settings, but the mortality is nearly 30% in low resource settings. And why is that? Is that because they present late or because of what we do here? Here's some data just highlighting the proportion of populations in Africa that live within 2 hours travel time of a hospital. And what you can see is that for large chunks of this continent, it takes people more than 2 hours, often sitting on the back of a motorbike. So if we want people to access healthcare services, we have to provide services that are available to them within a reasonable distance from their homes. Even within Cape Town, in a study we did some years ago, what we realized is that for most people living in metropolitan Cape Town, the nearest facility was on average or median about 2 kilometers from their home. But the nearest facility after hours, and I'll remind you that 3/4 of the week is after hours, was 6-kilometer transport and the public transport after hours. So we have to talk about accessibility. Once people get to healthcare services, we really need to ensure that this is then right the operational phase of a huge worldwide the world. And that has huge potential to improve the outcomes of patients who are critically ill. But we have to make sure that provision of oxygen comes together with knowledge on how to use it and monitor it safely, how to actually use intravenous fluids, and make sure that people who actually get to healthcare services receive the sorts of care that they need. And this is just some wonderful data from some years ago from work that Liz Molyneux and others did in Blantyre and Malawi, where they showed that simply by reorganizing pathways and making sure that patients were seen by appropriately trained people with the right expertise in the right timing, they were able to drop mortality in this group by 50% at minimal expense. And so we do have to put a lot of focus on how do we actually put systems in place to monitor them. And that really is just highlighted that healthcare services need to be efficient, effective, and functional. But we also need to get into the system of highlighting what do we do with children who have recovered ostensibly from sepsis in a hospital and are now being sent home. And we have to make sure that we find ways of breaking the cycle that got them sick in the first place. Finally, one of the things that has happened within the last couple of years is the development of the pediatric sepsis score and the new definitions of sepsis. If we are to improve the quality of care and the outcomes of children with sepsis, one of the first things we have to start doing is to collect the data. And I think now that we have a set of definitions that are potentially functional, that are evidence-based, we now need to roll those out, make sure that people across the world are able to collect the data, and that data needs to be part of routine clinical care, not an add-on on top of it, so that we can actually start doing the plan, do, improve cycles as we look at patients with sepsis. And so I just want to leave you with the sense that we can and must prevent the development of sepsis, particularly in vulnerable populations. And those interventions are going to have to happen at multiple levels, all the way out from the community, focusing on high-risk populations such as displaced peoples, all the way through to organizing structures in healthcare services. Those healthcare services have to be accessible both in time and in distance. And when you get there, things need to work. And the drugs, the oxygen, the peripherals such as fluids need to be there. So thank you for your attention, and I'd be very happy to answer any questions.
Thank you so much, Dr. Argent. And unfortunately, we're running out of time. So if there are any questions that will be sent, maybe we can share it over with you. So moving on to the next speaker, Professor Sheila Myatra, and she's going to talk about tailoring sepsis management to resource-poor settings. So Sheila is a professor in critical care medicine working in a mixed medical surgical ICU at the Tata Memorial Hospital in Mumbai, India. She's the immediate past president of the Indian Society of Critical Care Medicine and chair of Intensive and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiologists. She's the past president of the All India Difficult Airway Association. She's a member of the Surviving Sepsis Campaign Research Committee, the COVID Guidelines Committee, and the 2025 Surviving Sepsis Campaign Guidelines Committee as well. And again, she's going to talk about tailoring sepsis management to resource-poor settings. So the floor is yours.
Thank you so much for that kind introduction, and greetings from Mumbai, India. At the outset, I'd like to thank the organizers of WSC 2025 for giving me this opportunity. I'm going to be speaking about how we can tailor sepsis management to resource-poor settings, and I'm also going to be speaking about a recent global consensus, Delphi, the results of this on this topic. Now, just to give you a little bit of background, and as was published in the Lancet paper, the Global Burden of Sepsis, Global Burden of Disease 2017 study showed that there were estimated 50 million cases of sepsis with almost 11 million sepsis-related deaths. And interestingly, 85% of the global mortality caused by infections comes from the low and middle income countries. And this is a very nice article published in Intensive Care Medicine led by Marcus Schulz, which highlights the challenges in the management of sepsis in ICUs, especially in ICUs in resource-poor settings, and provides suggestions. And if you look at some of the the challenges, if you just look at the burden of disease, there's very scant systematically collected epidemiological data from LMICs, while the burden of disease and mortality is highest in this place. And it's not only the infections that are acquired in the community, but also the nosocomial infections that are several-fold higher in the low middle-income countries. And while the case fatality attributable sepsis in high-income countries has been decreasing over the last few decades, the case fatality rates in low middle-income countries remain high. These images are not unfamiliar to those who come from low middle income countries, and the reasons why nosocomial infections are so high, if you look at the crowding and various practices, you can understand why the infections are high. And this is, of course, also related to the resources and the cost constraints that exist in these regions. Now, another interesting aspect and challenge is the causative pathogens and the antimicrobial resistance. Now, this has also been described by the previous speaker. Now, if you look at the antimicrobial resistance in these regions are usually very high. And the causative pathogens are not all the same. It's not always bacterial sepsis, but also other, protozoal infections, tropical infections, viral infections, whether it's malaria, dengue, tuberculosis, etc., which are different. So the pathogens are different, and the pathophysiology of these pathogenesis is also very different. And these need to be considered when we're looking at the management of infections in these regions. And of course, most importantly, the poor availability and also the cost of critical care. If you look at the ICU capacities, they're much lower than the other high resource countries, and sometimes very low numbers, and there's wide variability. In addition, especially there's rapidly expanding urban population in the LMICs, and this again leads to increased cost caseload. And when we look at the cost of critical care, while the cost of critical care in the low income countries may be low, we have to look at the cost in a little different way, because we have to look at it in the context of the GDP of the country and also the government expenditure on health, which is usually very low in these low income countries. And most of the expenditure on health actually comes from out-of-pocket expenditure. Now, we have wonderful global guidelines that are available from the Surviving Sepsis Campaign guideline published both by the SCCM and the ESICM. And these guidelines are wonderful and robust evidence-based guidelines. Now, but when you look at the applicability of these existing guidelines to resource-limited settings, they are focused primarily on high-income countries. And there are multiple studies that have already shown there are various contextual factors that I'm going to be talking about that restrict the applicability of these international guidelines in many low resource settings. And most importantly, there are some aspects that the international guidelines don't address. For example, a majority of our patients, critically ill patients, are managed outside the intensive care unit. So how do we safely manage these patients outside the intensive care unit? Where do we locate them? And what is the minimal monitoring? What are the triggers for escalation? So guidance related to this is not provided in the international guidelines. Now, this all started, when we did this Delphi for India and the Indian Society of Critical Care Medicine. We published a position statement based on consensus Delphi by experts in the country on sepsis management in resource-limited settings within India. And then we said, why don't we extend it forward? And this was a proposal given to the Asia Pacific Sepsis Alliance. And that why don't we do a global Delphi to address this issue on management of sepsis in low resource settings? And that's what we went ahead and did. And we involved 70% of the experts from the low middle income countries and 30% from the high income countries. And this was the result of this global Delphi. And it was a publication in Intensive Care Medicine that happened recently. And we were able to get these experts together and get consensus on various aspects of management of sepsis in low resource settings. I'm very happy to lead this, and you can see various names of various experts, and the first author was Louise Thwaites, and we were able to generate 23 clinical practice statements. And in the interest of time, I won't be able to discuss all of this, but I'll be able to highlight some aspects of this. And as you can see, this is geographical distribution of the expert panels, and 70% were from low middle income countries. Now, I'll put you through some of the guidance that was provided in this consensus Delphi, and we address the timing, the transfer, the setting for clinical management, and also the diagnostics in adults patients with sepsis suspected infection. And I'll talk a bit about the timing, transfer, and setting for clinical management, because as I mentioned earlier, a lot of times these patients are managed outside the intensive unit, and we need clear guidance as to at what time should we transfer and how should we transfer and how should we manage these patients safely. So guidance on, what was provided was that there should be clinical and operational triggers for escalating the level of care, and various factors should be considered before transporting the patient. What is the distance? What is availability of staff? What access to diagnostic and therapeutic interventions are available? And what is the clinical support that is needed for the safe transport? And the guidance provided was that at the minimum, prior to transfer, the patient should at least undergo clinical assessment, receive appropriate airway maintenance and respiratory support, and oxygen supplementation, and also have IV access and get fluids and antimicrobials if it's possible. Now, if you're managing the patient outside the intensive care unit, the guidance that was provided is that there should be at least a virtual consultation with a critical care specialist via phone or telemedicine to guide the clinical management. And there should be a protocol for escalation should be available and in place. And basic medical imaging such as X-ray, ultrasound should be there. There should also be access to source control, and also staff who could monitor do basic monitorings for these patients should be available. So this was the guidance that was provided for managing the patients outside the intensive care unit. There were a lot of guidance for hemodynamic monitoring, antimicrobials, and respiratory management. I'll touch a bit on this. Now, hemodynamic monitoring And since hemodynamic monitors, advanced hemodynamic monitoring is not available, we focused a lot on clinical assessment. And we said clinical parameters such as capillary refill time, urine output can guide the resuscitation, especially when even serum lactates are not available. And when you don't have advanced cardiac hemodynamic monitors like cardiac output monitoring, etc., then even simple things like fluid therapy can be guided by fluid challenge or pulse pressure variation, which only requires an arterial line, tidal volume challenge, which uses pulse pressure variation, or passive leg raising test used with pulse pressure variation may be used, and even ultrasound. Some people think that, may say that ultrasound is expensive, but a lot of these centers get donation of an ultrasound machine, and there aren't the cost of disposables. Regarding the management, fluid management, we said whenever balanced salt solution was indicated, recognizing that this is expensive, we said non-proprietary balanced salt solutions like Linger lactate or Hartmann solutions may be used. And we also highlighted that there may be special considerations regarding the volume of fluid that is used for resuscitation in sepsis patients, because not all facilities may have, expertise or even the adequate number of ventilators required if there's fluid overload of these patients and they require mechanical ventilation. Again, regarding vasopressors, the guidance was that epinephrine is acceptable if norepinephrine and vasopressor are unavailable. And the Surviving Sepsis Campaign guidelines already recommend that vasopressors may be initiated, but we suggested that they may also be continued through the peripheral line if central venous access is not available or there is an expertise to use it. Now, one of the most controversial recommendations of the Surviving Sepsis Campaign guidelines is the use of the 30 ml per kg of the crystalloid fluid over 3 years, as you all know. And this might be a special concern in resource-limited settings, especially because I've already mentioned the availability of the ventilators may not be there. And soon after these guidelines were published, along with Professor Jean-Louis Vincent, we published this guidance on how we could equilibrate the Surviving Sepsis Campaign guidelines with individualized care. So while being within the framework, what we could do to individualize our care. And there were about 20 recommendations that were given, but I'll just highlight the one on the fluid management. And what we said is that we could give, start by not giving 30, but in a patient with septic shock, we could start by giving about 10 ml per kg. And then you could assess the patient over the next 30 to 60 minutes. And then you can see the response. For example, if there's worsening tachypnea or fall in oxygen saturation, we might stop the fluid. Or if the patient's the shock persists and there are fluid losses, etc., we might give more fluid after looking at fluid responsiveness. So this is a more individualized way of looking at the fluid management. And I like this paper very much because it can be quite useful in resource-limited settings. And then coming to antimicrobial therapy, again, concerns because of the high antimicrobial resistance and also the clinical load of infections. And we said whenever there's a high likelihood of sepsis or septic shock, antimicrobials should be started within 1 hour. And for patients with possible sepsis or septic shock, where investigations are not available or you can't rule out that this is a non-infectious cause and there's a high probability, then antimicrobials should be administered without delay. And also considering the parasitic agents and the load, we said that we should not delay administering antiparasitic agents in these patients. And when the source has been adequately controlled, we could go by clinical improvement, and improving in the trend of white cell count was the consensus for actually stopping antimicrobials. In the interest of time, I haven't been able to talk about all the guidance that was provided by the consensus statements, but I really urge you to read this paper because there's some really useful information here provided. I'll end by giving the take-home message. And as I've highlighted, there are several challenges in the management of sepsis in low resource settings. And this global consensus that I presented on septic management in low resource settings, I think it should complement the current international guidelines that are available because it addresses the various contextual factors that I've talked about that may restrict the applicability of the international guidelines in these settings, and also provide additional guidelines for specific considerations, which I've mentioned that exist in resource limited settings for which guidance is not provided. But of course, it's really important that we have future research in this area to assess the feasibility and also the adoption of the effects of these practice statements and address the remaining uncertainties. So I leave you with this. Coming up very soon is the Surviving Sepsis Campaign International Guidelines that will come in 2026. And we also have the SCCM guidelines for management of sepsis in low resource settings that's also coming up soon. And with that, I thank you very much for your attention.
Thank you very much, Dr. Myatra. And we move on to the next speaker. So the next speaker is Dr. Louise Thwaites. She's going to be talking about revolutionizing patient care with wearables and remote monitoring. So Louise is a clinical researcher and a member of the emerging infections group at OCRO. She's an associate professor in the Center of Tropical Medicine and Global Health at the University of Oxford, and honorary consultant at Oxford University Hospitals Trust. Research focuses on the care of critically ill patients in resource-restricted settings, and she has spent much of her career engaged in research into tetanus. She's an expert consultant to the World Health Organization. She's a member of the Critical Care Asia Network and leads the Guidelines and Policy Working Group of the Asia Pacific Sepsis Alliance, as well as being a member of the Sepsis in Resource Limited Settings Expert Consensus Recommendations Group of the European Society of Intensive Care Medicine and the Mehaidul Oxford Research Unit. So, Dr. Thwaites, the floor is yours.
Thank you, Abdulelah. And thank you, everybody, for listening this morning. Particularly thanks to Sheila and Andrew, who have given me a really great introduction for what I'm going to say today. I'm going to be highlighting some areas where I think new technologies can be a particular advantage in caring for patients with sepsis in low resource settings. So just reminding us very briefly, because this has been already mentioned, what are the main barriers for this? This is a point prevalence study that was recently published looking at patients more generally with critical illness in 180 sites, 22 countries in Africa. And the real headlines for this are, firstly, that patients with infections make up a large number of patients with critical illness. So 25%, quarter of patients with critical illness had infections as a main reason for hospital admission. And as Sheila and Andrew both said, the majority of patients are cared for outside of critical care units. There are often lacking staff with the skills to care for these patients, and very often equipment lacking as well. And Sheila's given us a great introduction about the Delphi project, which she and the Asia Pacific Sepsis Alliance and other collaborators were part of, where we tried to come up with some recommendations on how best we can start to manage patients in these settings, given this lack of equipment and staff often. And as Sheila already mentioned, some of the recommendations concern the possibility of telemedicine, but nevertheless the need for carrying out observations and monitoring patients carefully wherever they're cared for within a healthcare setting. So I'm going to talk now a little bit about wearable devices and how these might start to fill the gaps. When I'm talking about wearables, I'm really going to be meaning patch ECG devices or simple pulse oximeters. But these attach essentially to the patient, so they'll move with the patient, and they usually use something like Bluetooth technology and can allow also remote monitoring of patients. They're battery-driven devices, which can be an advantage in low healthcare resource setting. And because they move with the patient in overcrowded wards or where patients are being moved around a lot, then they can have some very useful flexibility features. Also, importantly, they capitalize on what often are relatively well-developed infrastructures in terms of telecommunications and internet in many low and middle-income countries. So in contrast to high-income settings, where most of the talk about wearable devices is to manage patients at home or in outpatient settings, I think where we want to look at in sepsis at the moment in this context, monitor patients who are hospitalized. And this is an example of work that we did in Vietnam during COVID, when we were already working with some low-cost wearable pulse oximeters, but the lack of equipment and the staff to monitor patients when the COVID wave really hit us in Ho Chi Minh City meant that we really had to rapidly upscale this project to be able to monitor multiple patients and meet the need that was present in the hospital system then. So we used simple, low-cost pulse oximeters. These were connected via tablets, but also to a remote monitoring platform working with a local partner. And that meant we essentially had a central monitoring capacity, so we could monitor patients in multiple wards at the same time. And with our very limited number of staff, they could at least keep an eye on various patients. We had a very simple traffic light system. I don't know if you can see this bottom left hand, where if any of the parameters that were being measured, pulse ox, SpO2, respiratory rate or heart rate, dropped below a certain threshold, kind of red light or an orange light went on depending on the severity to alert the staff to that. So more broadly in terms of sepsis, I think there's a lot of potential going forward with wearables, not just in terms of simple monitoring and telemedicine, but bringing individualized risk prediction and individualized care forward. So in high income settings at the moment, there's a lot of work bringing risk prediction tools into electronic healthcare record systems. Maybe some of you are already using these to develop early warning scores and to notify healthcare staff about patients who are getting sick early. But in many, many low middle income countries, those data are not available. Records are still very much paper-based, so any type of risk prediction needs to be manually done. But wearables really offer us now the possibility of moving beyond that and directly linking patient data to outcomes. And in Bangladesh, this group have done this recently in children admitted to hospital with sepsis using a patch ECG monitor that was connected to a computer. This was able to extract physiological variables, heart rate, respiratory rate, heart rate variability, and temperature from the patch, and predict children that were going to have advanced sepsis. They wanted to check feasibility of the system, so they also compared at the same time with manually observed data. They found that the data quality from the patch device was very good, and also that it correlated very well with the manually measured variables. But I think what's really interesting is if you look at the bottom part of the screen here, which with the models that they developed, they use machine learning. On the left-hand side, they threw all the data that was available. So all the data from the patch device, the manual data, as well as additional things like age, what the patient looked like, a presentation, and tried to make a risk prediction model of children going on to more severe advanced sepsis. And you can see the blue line is the model and the purple is the confidence limits, that it's not a great predictive model. But they then selected the best features from that and made the middle model, which worked very nicely. But most interestingly, I think, from that, they selected just the features that were available from the wearable devices. And you can see the model there performs nearly as well as the best overall model in predicting advanced sepsis. And that needed no additional manual monitoring data at all. In Vietnam, with me and my team, we're pursuing a similar approach using low-cost wearables, again, either pulse oximeters or patch ECG devices. A slightly different approach in terms of the analysis, in the sense that we're using AI techniques that don't just extract summary data from these devices, but actually look at the whole waveform signal, so either the ECG or the pulse oximetry trace. And our models, which we're running in sepsis, tetanus, and other infectious diseases, are running very well and appear to be functioning much better than conventional scores. And maybe that's not surprising, because we know already what important physiological information is contained in these waveforms. And by analysing the whole waveform, we hope that we're really putting most of that into our models. But of course, we want to employ these within real healthcare systems, and Andrew was talking about that earlier, and these are complex systems, particularly in resource-limited settings. And so there's a lot of work still being done. Currently in Vietnam, we're using a pulse oximetry-based model that runs through a computer, alerts a doctor via a smartphone, who can then go and check the patient. But certainly in terms of understanding how these systems work in real life compared to nice models which are done offline, this is a whole additional layer of work that needs to be done. And currently we're very much at an early stage of that throughout the world. I think what we've also realized, of course, is that there are many, many other factors we need to take account of. Using wearable devices in healthcare settings actually does create work as well for healthcare staff. Devices need changing, batteries need charging. It's a new way of working they have to become familiar with. Certainly, there's a concern about alarm fatigue. If any of you have been into critical care units or hospitals in many low resource settings, there's a lot of alarms going off, and staff simply haven't got the time to be addressing all of them. So we need to think very carefully about doing it. And of course, what we really don't want to do is take staff away from the bedside and the patients. And I'm just going to finish with some data actually from a high income setting from the UK, just to illustrate this. This is a study looking at wearable devices post-operatively to see if continual data from wearable devices could help predict patients with post-operative complications earlier than manual monitoring, routine monitoring by nurses. The top panel shows if they built in single parameter alerts to those wearable devices, a bit like that traffic light system I mentioned earlier. And you can see probably the large amount of red there is in that top figure. The red are false positive alerts and the green are true positives. So essentially, if you have single parameter alerts, you have a lot of false alerts for staff. And that's obviously very tiresome if you're already busy looking after patients and have to respond to those. If those parameters are combined into early warning scores, however, the number of alerts decreases. And the middle panel is showing the early warning scores related to the wearable devices on the left, and the right-hand side manually ones. What you can see there is that the sensitivity of those for detecting deterioration is much improved with the wearable devices compared to the nursing observations on the right. But before we get too excited, what the authors also did, which I think is really interesting, they also looked at something else. They looked at what the nurses were doing separately, which was filling in concern sheets, which they did regularly throughout the post-operative period, and filled in if they thought they had a concern about a patient. And what you can see is that the patients who did go on to experience post-operative complications, the nurses picked up that in their concerns, and no concerns were in the control group. And I think that just reminds us that nurses do a whole lot more than just take observations, and we have to factor that in when we look at these systems. So just summing up, really, I think wearable devices really could be flexible and a cost-effective way of monitoring patients in low-resource settings. There's certainly some really exciting possibilities for new technologies coming in, but they should absolutely not replace healthcare staff who should be there if at all possible. So thank you. I think I'm done.
Thank you so much. It sounds like we have a couple of minutes left, so I don't see questions on the questions. But I may ask you, how can wearable technology be used and implemented in LMIC where the basic digital infrastructure is not there in some countries?
Yeah, I think that is a challenge. Most of the wearable are using local Bluetooth connections. So at a very basic level, we have used them just as additional monitors, by the bedside or slightly further away. So you can do that without good internet connectivity, but you're absolutely right. I think to really maximize them, you do need to be able to use those data if you want to be able to run early warning scores. It can be done locally, but again, you need to be having more complicated, perhaps, local computer systems to do that.
Great. Well, thank you so much. So we move on to the next speaker. So the next speaker is going to be Elanor Gomersall, and she's going to talk about results from the Delphi process, what every medical student should know. So I am going to introduce Elanor. So she's a third-year resident specializing in intensive care in Hong Kong. She graduated from the Chinese University of Hong Kong, and during her time in medical school, developed an interest in medical education and intensive care. During her time As a medical student, she conducted research on sepsis-related competencies for medical students using Delphi techniques with an aim to highlight essential skills and knowledge for future physicians in managing sepsis effectively. In addition to clinical duties, Elanor plays an active role in monitoring junior colleagues and conducting clinical teaching for medical students. In the future, she hopes to play a larger role in developing and teaching intensive care-related educational course content for medical students. So, Elanor, the floor is yours.
Thank you. Thank you for the introduction. So today I will be presenting our recently published paper on core sepsis-related competencies for medical students, which is an international consensus by Delphi technique. And particularly, I want to focus on the differences in the results between the high income countries and the low middle income countries, and also provide some explanations for these differences and also some implications. So just to give a little bit of background, sepsis is a disease characterized by life-threatening organ dysfunction resulting from the body's dysregulated response to infection. It affects about 48.9 million patients globally and also accounts for 11 million deaths each year, as well as significant long-term morbidity such as chronic physical, mental, and cognitive deficits, and it requires early recognition and treatment. So the incidence and impact of sepsis is also likely to be significantly higher in low middle income countries compared to high income countries. And this can be due to various factors such as limited access to healthcare, delayed diagnosis and treatment, and also the prevalence of infectious diseases in these regions. Low middle income countries also may have insufficient resources necessary for the diagnosis and management of sepsis, such as lab resources, imaging, and drug resources. And on top of this, the majority of research on sepsis and clinical guidelines have been developed in high income countries. And this may not necessarily be applicable to low income countries because of their differences in resource availability, epidemiology, and healthcare access. So because of the high incidence, morbidity, and mortality of sepsis around the World Health Assembly identified educational development for healthcare workers as a resolution to improve prevention and diagnosis of sepsis and also its management. So in order to educate effectively, there needs to be core competencies established. And in fact, a core competency framework was identified as a priority at a WHO sepsis technical expert meeting. Since all doctors should be able to manage sepsis, we focus particularly on medical student education, as we felt that teaching medical students would be an effective way to ensure that all future doctors would have sufficient ability to diagnose, treat, and treat septic patients. However, there's currently no consensus on what medical students should be able to do by the time that they graduate regarding sepsis management. So the aim of this study was to determine which competencies medical students should have by the time they graduate regarding sepsis recognition and management in order to manage sepsis effectively as junior doctors. And so we did this by assembling a panel of experts from various fields to advise on these competencies. Given the high incidence of sepsis in low-income countries, as well as the unique challenges, such as increased prevalence of infectious diseases, lack of resources, lack of healthcare access, we also wanted to identify competencies specific to these particular regions. And so we included study participants from both high-income and low-income countries. So now I just want to focus a bit more on the key differences in our findings, and how these differences may also affect the approach to medical student education. So one of the big differences we noticed in our results was the specific mention of specific diseases such as malaria and dengue in the low-income group. So knowing how to diagnose malaria was considered essential, and knowing the differences in prognosis and also how dengue prevents differently was considered moderately important. Whereas understandably, this wasn't mentioned at all in the high-income group. So this is likely due to the differences in epidemiology of sepsis in high-income and low-income countries. The majority of sepsis cases in high-income countries is caused by bacterial infection, and this is the focus of most of the medical literature and also education. But in low-income countries, many sepsis cases are also caused by protozoal disease such as malaria or viral diseases such as measles, dengue, or hemorrhagic fever. And so the knowledge regarding the pathophysiology and the treatment may not be necessarily interchangeable between high-income and low-income countries. An example of this is in malaria, the causes of vital organ failure could be due to a blocked microcirculation from sequestered infected red blood cell biomass. And also, unlike in bacterial sepsis, fluid boluses are not recommended for non-hypotensive hyperlactemic patients with malaria. And this just highlights how the knowledge requirements differ between the different regions and how the focus of medical education also has to be different. The management of sepsis with regards to fluid is also different between high and low income countries. And this is reflected here in these competencies. So in high income countries, it was thought that medical students should know the indications for fluid resuscitation. Whereas in low income countries, they specifically mentioned that they should know about the adverse effects of fluid resuscitation. With limited access to positive pressure ventilation and higher morbidity or mortality associated with invasive ventilation in low-income countries, the ability to effectively correct the adverse consequences of excessive fluid administration, such as acute fluid overload, would be more limited in these settings. And as mentioned, a restricted fluid therapy is also preferable for sepsis caused by malaria and dengue, which accounts for a higher proportion of sepsis in low-income countries. And so understanding the differences in the disease process and the differences in skills required to effectively and safely fluid resuscitate further emphasizes the differences in education requirements between these regions. The low-income countries, we also noticed, put a greater emphasis on competencies regarding pediatric sepsis compared to the high-income countries. So in high-income countries, the only mention of pediatrics was that students should know the common foci of infection in children and adults, whereas in low-income countries, it was specifically mentioned that students should be able to examine a child for possible causes of sepsis, including ear, throat, and skin, and also know more about pediatric shock. So this may be a reflection of the differences in access to specialist pediatric care in low-income and high-income countries. The pediatric population constitutes a significant proportion of sepsis cases worldwide, and low middle-income countries, particularly in sub-Saharan Africa, are particularly affected. However, the density of pediatric specialists is significantly lower in these areas. For example, only 0.5 pediatricians per 100,000 children in low-income countries compared to a global mean of 32. And in a lot of these countries, the significant load of primary care may be carried out by general non-physician clinicians or nurses. And so it would be more reasonable to expect a medical student to have a greater understanding and knowledge regarding the management of pediatric sepsis, as the access to pediatric specialist care is likely to be a lot more limited. And so therefore, the direction of medical education also has to be different. Another example of different skills that are required between low and high income countries. In low-income countries, it was also mentioned that students should be able to clean a wound and insert a urinary catheter properly, whereas this wasn't really mentioned in high-income countries. In high-income countries, these are tasks that would probably normally be done by nurses, whereas in low-income countries, if junior doctors are working on their own in a rural setting, they may need to be able to do this by themselves due to other manpower constraints. And another noticeable difference were suggestions regarding infection control. So in low-income countries, it was only mentioned that students should be able to perform hand hygiene properly, whereas in high-income countries, they also emphasized aseptic technique, gloving and gowning, and being able to don and remove personal protective equipment. And this is understandable given that there is a lack of resources in low-income countries, such as goggles, gowns, face masks, etc. Lastly, in low-income countries, they also specifically included the consideration of resource constraints and the cost of treatment as essential and important competencies, while these weren't mentioned at all in the high-income group. So in a high-income country, medical students and junior doctors would never be expected to manage the resources and financial constraints of their healthcare system. But in low-income countries, many junior doctors may be managing patients on their own, and in these countries, financial aid and healthcare is limited. And so patients and their families may need to pay out of pocket. And so for this reason, it's important that these doctors consider the cost of treatment and the available resources. So in summary, these results highlight the differences between low middle income countries and high income countries. Low income countries face unique challenges that may not be accounted for in the medical curricula developed in high income countries. And in important ways, the medical curriculum regarding sepsis also needs to be different in different parts of the world. And so our research provides a framework for the development of medical student curricula in different regions. And because we've identified these key competencies required in a sepsis curriculum, the testing of new developed curricula can also be facilitated. So thank you very much for listening, and thank you for inviting me to speak on this topic.
Thank you very much, Elanor. And I don't see any question, but we still have a couple of minutes, so I will ask you a question. Given the global variation in medical curricula, how can sepsis education based on your Delphi findings be standardized internationally without losing local relevance?
I think because we've developed competencies for high and low income countries. So these can be sort of taken by a hospital or a school in that region, and then they can look at these competencies and design their own curricula, particularly picking the ones that may be more relevant to their local region. So, for example, if malaria is not particularly prevalent in a low-income country, they may not focus so much on this, but it just provides an initial foundation and framework by which they can then sort of tailor their own curriculum.
Perfect. Well, thank you so much.
Thank you very much.
And then we're going to move on to the next speaker. So the next speaker is Victor Akelo, and he's going to be talking about understanding sepsis, morbidity, mortality, and health-seeking behavior for sepsis through longitudinal surveillance within health and demographic surveillance sites. So Victor is a medical doctor based at the Center for Global Health Research of the Kenya Medical Research Institute, KEMRI, in Kenya, as part of the collaboration between KEMRI, Emory University, LSTM, and the US's CDC. He serves as a senior science director for site strategy and implementation for the Child Health and Mortality Prevention Surveillance Network, and recently joined LSTM's Department for Clinical Sciences, where he serves as Kenya's site director and principal investigator of the Kenya CHAM site. He previously served as the CDC Kenya's senior public health advisor and principal research officer, chief of HIV research branch with KEMRI in Kisumu, leading various clinical trials, research, and programs. So, Victor, the floor is yours.
Thanks so much. So I'll start my presentations by talking a little bit about health and demographic surveillance platforms that we do run here in Western Kenya. So we do have two platforms, a rural catchment area that has a population of about 100,000 populations with under 5 mortality estimated to be about 60 per 1,000 live births. And an informal urban settlement, which is in another county, both of still also in Western Kenya, with a population of close to about 76,000. In this particular place, the under 5 mortality is estimated to be about 45 per 1,000 live births. So it is within these two health and demographic surveillance where we conduct our studies and layer various activities. And as I've mentioned, we do quite a bit, including layering infectious disease research, epidemiological studies, and evaluation of public health intervention. We conduct household interviews in these DSS sites twice a year using structured questionnaire, and are able to monitor health drivers of populations such as births, deaths, causes of death, verbal autopsy that is also conducted to try to provide cause of death for this case. So just very briefly on sepsis as a cause of death in under 5 children, based on just verbal autopsy data from these two catchment area. So between 2027 to October 2024, we've conducted over 1,700 verbal autopsies each for children under 5 years of age, excluding stillbirths distributed as you can see. Conducted some inter-VA analysis to determine causes of death, and up to 10% of them had sepsis as a cause of death. If you look at it in terms of the trend over time, again, just based on verbal autopsy alone, you may be able to say that there is some decline in sepsis by verbal autopsies based on the verbal autopsy data, currently at about 10%, but as you are aware, there are usually limitations with the verbal autopsy in terms of sensitivities and such. And currently, we are also not collecting morbidity data, which is something that we were doing previously as syndromic-based to be able to understand sepsis better. But we have layered a mortality surveillance platform, which has just been introduced earlier there, which uses minimal invasive tissue sampling methodology. And I'll talk a little bit more about that, comparing the sepsis in that data set, that project, as opposed to, for example, this verbal autopsy data, and see what we get. The project is called Child Health and Mortality Prevention Project, CHAMS, in Kenya. It does run in several countries, has been running since 2016, deploy rigorous scientific methods to investigate causes of death in sites. And the goal is to provide funding to the people that can act and ensure that we have evidence-based interventions that can be used to prevent death. We do work in several countries, 7 of them in Sub-Saharan Africa and 2 Southeast Asia. In most of these places, the under-5 mortality is estimated to be more than 50 per 1,000 live birth. There's multidisciplinary teams and partners that works together to be able to conduct this study. How do we do it? We collect data, notifications within 24 hours, parents provide informed consents. We still also do bowel autopsy also as part of the CHAMS, clinical record reviews and photograph measurements, physical measurement. And we also do collect specimens such as blood, CSF, and some of the tissues, lung, liver, that goes for further pathology examination. We do cultures, rapid tests for HIV, TB, and malaria, and then we do some molecular tests for infectious organisms. All this comes together and is reviewed by a team that we call cause of death determination panel to give us some insights into what is causing deaths. So I'll basically just present a bit on the sepsis data from this study, from this project as well. But first, looking at the number of cases that we have had, over 1,100 deaths that have gone through cause of death determination successfully, and distribution, we have 29% neonates, 42% children 1 to 60 years of age. So looking at neonates, sepsis do contribute up to 25% of death in the causal chain, which means sepsis appear either as immediate cause of death or as a morbid cause of death, or just the only condition, which then makes it also an underlying cause of death. In our rural catchment area, which is called Karemo, at 25%, and when we look at the urban one, at 18% there as at number 3 for neonates. When we think about the infants, we see again sepsis contributing to about 28% of those deaths, at 28%, whether we are looking at the rural sites in Myatra, in Karemo, and the urban sites in Myatra. The trends of sepsis related, as you could be able to see from here, it's higher. If you look at the bowel autopsy trend, we are talking about 10%, but when you look at the CHAMS rigorous cause of death determination, we are looking at up to 36%, and it seems like it's probably even increasing in terms of where sepsis is in the causal chain. And then when we look at this burden by breaking it a little bit by the age types of groups, we do see sepsis is significantly high, especially among late neonates, 7 to 27 days, up to 60%. Sepsis do appear somewhere as a cause of death for these neonates. CHAMS also do go further and try to review in terms of what are some of the pathogens that leads to sepsis, and we could be able to see Klebsiella pneumoniae, Escherichia coli, Streptococcus pneumoniae are some of the top etiologies in all the different age types. And this is the same whether you are now able to look at it by different age groups, whether you're talking about death in the first 24 hours or you're talking about 12 to 59 months. We still see these 3 pathogens are still appearing as the top etiology for the causes of sepsis. Again, the other major finding that we usually see is that we have up to 3 pathogens causing sepsis. In one case, up to 34% to almost over 50% in infants and neonates, where more than one pathogen is causing sepsis in the case. Majority of these cases, 55%, nearly half of them had some underlying conditions, and those underlying conditions include either the child was malnourished, the child had HIV, had a predisposing low birth weight or to maturity, or congenital malformation that then predispose them to the sepsis infections, given the pathogens that we have just mentioned. Sepsis diagnosis in the health facilities, again, we do have 61% of them that were diagnosed in the health facilities, but it's important 61% of deaths occurred in the health facilities. But it's important to note that only about 9% of this sepsis was correctly diagnosed before death. We do diagnose sepsis post-mortem in this almost 9%. So significantly higher number of cases that were just either being treated as pneumonia or something else, but sepsis was not diagnosed. And when you look at just a tip on the investigation, 28% had blood chemistry, complete blood count performed, but none had peripheral blood culture or blood gas performed, as you would expect that you need to be able to do blood culture in this. And there are several challenges that goes with that, whether bottles are not available or some challenges in terms of the lab capacity to be able to do the blood cultures. And then 70% did receive any antibiotic for these cases. We do also try to review what could have been done differently to prevent this sepsis death at family and community levels based on the panel expert review. The significant use of traditional and over-the-counter medication that especially before these children are taken to the health facilities, at almost a quarter of them. And there's need to be able to improve home management of malnutrition. We do see a lot of malnutrition in the community before that predispose them to sepsis before they come over, and improve detections of danger signs right from the household levels to be able to make appropriate referrals, increase emergency planning, and increase vaccination coverage are some of the top issues that needs to be addressed at the family and community level. When we look at the provider and the health facility, they still need to be able to adhere to the clinical guidelines, the country's guidelines, to be able to ensure that it's implemented appropriately for sepsis management, improve documentation and filing, improve referral as appropriate because we have different facility tier levels, and reduce pharmacy stock out and increase lab capacity to be able to address this. So in conclusion, we do have over a third of descendants enrolled in CHAMS and sepsis somewhere in the causal chain, nearly 3 times higher than what the verbal autopsy estimate. It's important to note that this is a deceased cohort. We don't have a morbidity data, which is something that we are looking into. And only 9% of these cases were diagnosed before death. The mortality trend based on CHAMS data seems to change over time, including the last 6 months. So it means we need to be able to interrogate this data further and see whether, why are some of the actions that we have been implementing not quite working in reducing the sepsis. Late neonates had the highest burden of sepsis in causal chain, and some of the top etiologies such as Klebsiella pneumoniae, E. coli, and Streptococcus could be able to help with prioritizing the management. More than half of these cases had underlying conditions, but there are also critical gaps in healthcare seeking behavior and management of sepsis, such as over-reliance by family on over-the-counter medication, use of traditional medicines, poor adherence to clinical guidelines. So highly seeking of healthcare and high index of clinical suspicion coupled with training on optimal management could be able to help reduce sepsis in under 5. In future, we're planning to be able to employ what we call MIDS-Lite, which is not as extensive as CHAMS is, but can be able to a streamed down version of it that can be able to be implemented in a much wider area on a sample cases to be able to help with this. And then morbidity survey also to help with some of the closing some of the gaps that we see. Thank you.
Thank you so much. So I have a question here for you. How do you define mortality of sepsis? For instance, if patient was admitted with cardiogenic shock complicated by acute myocardial infarction, then patient was acquired healthcare-associated pneumonia. Do you count this as death by sepsis?
So for CHAMS, given that we do use the mortality data, so we do have the histopathological information. So at least histopathological findings of sepsis features in at least 1 or 2, in at least 2 or more organs do qualify for sepsis. So we do, for example, we could be able to isolate some of those histopathological information in these 2 different tissues. And then for the pathogen, also they're isolating the pathogen in the 2 different tissues. And that can be done through the histopathological examinations. We do the immunohistochemical staining to be able to do that, some molecular PCR, both multiplex and singleplex, to be able to do that. We also do cultures to be able to verify some of those information.
Thank you. And there's another question here. What was your case definition for sepsis for community surveillance?
Yes, so that's a good question. So as I mentioned, that we are the sepsis in the community, we don't currently conduct the morbidity survey, which is something that we have planned, and we will be reviewing the tool for defining that, including fever and some of those, basically what I may call the IMCI definition for pediatric, in terms of defining sepsis for that particular one. But it's something that we are looking forward to be able to reviewing, which tools should we be able to use in the community to be able to define that. The data that are presented there is based on verbal autopsy at the community household, which is basically based on the WHO 2016 VA tool and the VA analytical tools such as the InterVA to be able to analyze that as sepsis.
Thank you very much, Dr. Akelo. We move on to the last speaker. The next speaker is Dr. Wiltrud Abels. She's going to be talking about simulations and Tele-Consultancy to narrow the divide in quality of care. So Wiltrud is a consultant specialist in critical care and in anesthesiology at the Charité University in Berlin. She has worked in her department's telemedical intensive care unit that is actively supporting quality intensive care for sepsis patients on a daily basis, providing consultations for colleagues in intensive care in Germany and beyond. Within the Sub-Saharan African Consortium for Advancement of Innovative Research and Care Sepsis, STARES, she's working on exploring the use of telemedicine for expediting sepsis care in Sub-Saharan Africa. She has continued to work for the German Sepsis Foundation since 2020 to support survivors of sepsis and their families and promote awareness and sepsis knowledge with a focus on the German region of Berlin and Brandenburg. Wiltrud, the floor is yours.
Thank you so much. Thanks for the kind introduction. I'm very glad very grateful also to Sheila and Louise for pointing out that telemedicine has made it into recent recommendations around sepsis care. And I'm going to talk a little bit about how the STARES consortium is exploring the use of telemedicine in Sub-Saharan Africa to improve quality of patient care. I always felt like the terminology in the field of e-health can sometimes be a little bit confusing. So I first wanted to look at what telemedicine actually means. Telemedicine refers to anything that is actually connected to the direct provision of care. It includes teleconsultation. So for instance, when a patient sees a doctor remotely via an app or on a provider basis. So when a specialist is consulted by another physician from remote to and is asked to provide recommendations on ongoing patient care. Telemedicine actually also includes distance learning formats, and both consultations and distance learning can happen in time with patient care, so synchronously with treatment, but also asynchronously with formats such as case management discussions or webinars and lectures. So telemedicine is more than just one thing. And according to the WHO definition, telemedicine refers to any provision of healthcare services wherever distance is a critical factor. It includes all professions in the team, not only physicians, but definitely nurses. And Louise just gracefully pointed out the role of nurses in sepsis care again, and everyone else in the team, really. Telemedicine definitely means using information and communication technologies. And we are actually very much and very often already doing that anyways, communicating about patient care via phone or sometimes on not necessarily health-related messenger apps like WhatsApp, or we meet on platforms like Zoom for exchange and training. Dedicated telemedical technology, though, technology that can bring the consultant to the bedside with an audiovisual connection, that can have many advantages, like, for example, improved security and protection for patient data. And that's obviously essential to think about. Telemedicine serves the purpose to remotely exchange information between providers and other providers, or patients and providers, for diagnosis, treatment, and also prevention of disease and injuries. And the ultimate goal of telemedicine is to advance the health of individuals or even communities. So this definition holds, I think, a space for quite a lot of things. And before I continue to talk about how we in the African German Research Network STARS are currently exploring the use of telemedicine for sepsis care, and how we, build our approach to strengthen capacity in clinical teams and also, support quality improvement, let me say this. Telemedicine is a tool, or maybe even a toolbox, not a treatment. This toolbox won't change anything on its own, but the way we use it, that might change something. The most important thing when implementing telemedicine, I think, is to ask yourself, how does any combination of these tools in the toolbox best serve the needs of my patient? How does it serve the providers? And how does it improve quality of care in the long run? This is important. Benefits of provider-to-provider telemedicine have been pointed out by the WHO. And in fact, healthcare workers, especially on lower levels of the system, appreciate the opportunity to talk to a specialist in an expert center. It reduces feelings of professional isolation, and they feel like it allows them to provide better quality of care with the support of an expert. In emergency care, it can be a tool that speeds up diagnosis and treatment, and in some settings also has reduced the length of stay in emergency units. At Charity Hospital, where I work, a telemedical ICU was initially established in 2017. My colleagues back then did a stepwise trial and found that remote daily ward rounds with a remote specialist from our expert center did improve adherence to quality indicators in critical care in smaller and medium-sized hospitals in Germany. Compared to baseline assessment, for instance, the adherence to measures for infection management, which is one of the indicators, significantly improved with the start of the intervention. And that's even if we already started from relatively high levels of adherence in all clusters in the first place. So telemedicine as an intervention can actually become a vehicle for improving quality of care. And thus, any evaluation of its effects should be, I think, along representative indicators of care quality, if those are available in the setting you're in. Now, how can an approach like this be translated and adapted into improving the quality of care for sepsis patients in a low-resource setting? I want to talk a little bit about how STARS is currently exploring telemedicine for exactly this purpose. Since we're still in the implementation phase, all of the following is really just an invitation to think about how telemedicine in any shape or form could serve to improve sepsis care in your own setting. So there wasn't a lot of evidence to start with when we set out that had a specific focus on sepsis. Only a few studies from intensive care settings. We do not know for sure that telemedicine can improve patient outcomes in sepsis, and it comes with potentially high costs and infrastructural challenges. Lack of internet, unstable electricity, lack of experience in hybrid and digital technology are a few of those. And looking at various other telemedical approaches in the African setting, even more challenges have been described, namely that sometimes setup of technology it doesn't support existing workflows, or that there can be resistance to change, or language barriers, or lack of buy-in from stakeholders. Varying cultural contexts and different perceptions about the role of technology in treating illness on the side of providers or on the side of patients can also pose barriers to using telemedicine. And it seems to me that there's a clear role for qualitative evaluation as well. For instance, at least exploring acceptability and usability in both patients and providers whenever a new approach is being implemented. The same studies, though, also found facilitators for success in telemedicine implementation. And those include sustained collaboration, like with international partners or with national providers of telemedical technology, because that can actually reduce costs. And sufficient training on the technology is a must, and SOPs to ensure patient data confidentiality and to make sure that recommendations in remote consultations are consistently rooted in current evidence, those are essential as well. What's also important is a systemic approach and pre-planning of an, at best, ongoing monitoring and evaluation throughout the implementation. Now, this sounds like a lot to consider, and it is, but there's guidance for anyone who is interested to implement telemedicine. The WHO has published a guide on the implementation of telemedicine in 2022, and you can see that also in this framework. The first step of the recipe is to define goals to answer the question, what is it specifically that I want to improve with telemedicine? And then who will do it and how will it work? So this is not something that cannot really be done from remote, but this needs a situational analysis. And this needs to be together with and actually led by the teams in the specific settings. You need local champions. Obviously, our common goal in STAIRS was and is to improve quality of care for sepsis patients. So what we did is we took our time to look at the specifics of a typical sepsis patient's pathway in our pilot settings, and we tried to identify the very points where any tool from the telemedicine toolbox or a combination of them could be used to support gaps. And working with the African Federation of Emergency on this from the start of it all, we quickly identified that telemedicine might have a role in supporting early recognition and initial treatment of sepsis in lower level facilities. And it could also support expediting referral to higher level centers for the most critically ill patients. Experts in the local referral centers from emergency medicine and intensive care were identified to be the best providers for the telemedical consultations, and distance learning formats, namely webinars and case discussions, also became part of the approach. All of this was developed in workshops in Berlin and in various discussions during site visits over the course of a bit more than the last year. Eventually, the approach became a multimodal quality improvement intervention consisting of a webinar series and direct synchronous telemedicine in emergency and intensive care in and between our piloting sites. Now, since there currently is no existing set of quality indicators for sepsis care and LMIC settings, part of the work was also to come up with specific measures that will allow us to evaluate the effects of this intervention on quality of care as the implementation progresses. As I've mentioned, the approach is currently in the implementation stage, so I'm certainly hopeful that we will be able to talk more about this in the coming years on this stage of the World Sepsis Congress. For now, I'm slowly coming to an end, but I'm going to take the opportunity to invite everyone here who is interested to register and join our webinar series, the Global Sepsis Lecture Series. STAIRS is collaborating, as I said, with the African Federation of Emergency Medicine and hopefully also soon with the African Sepsis Alliance to bring together speakers from Africa and beyond with an audience that is involved in frontline clinical care across the African continent. The Global Sepsis Lecture Series is meant as an interprofessional platform for knowledge exchange for physicians, nurses, and other members of clinical teams alike. And we started 2 weeks ago with an introductory session. You can see the upcoming topics and speakers here on this slide, and also please use this barcode to register if you're interested. All sessions will be uploaded as we go on our website. So now, as the very last thing, I just want to point out what I think is another interesting approach, so to speak, an invitation to think even further. Simulation-based training has become an integral part of many trainings in emergency, acute, or critical care, and many of you will be familiar with the concept. This group from India, in collaboration with the Children's Hospital in Philadelphia, took what I think is a very creative approach and combined simulation and telemedicine into telesimulation training. In this study, remote facilitators were actually using pre-recorded videos that were filmed with consent from actual patients in India to guide learners in the setting through scenarios in Zoom sessions. This group could actually show that during the time of intervention and after, shock reversal time in real-world patients as a measure of quality of care significantly improved. I think this goes to show that it is worthwhile to look at the toolbox of telemedicine and think about how that one can be used in different ways and, even combined with other successful approaches with an ultimate goal to improve quality of care for sepsis patients worldwide. I'm going to stop here. Thank you very, very much for your attention. And I am open to questions. Thanks.
Thank you so much, Wiltrud. So we have a couple of minutes for questions. I don't see any questions, so I will ask you a question. In your experience, how can teleconsultancy and simulation-based training be localized for frontline healthcare workers in LMIC who face language, bandwidth, and cultural constraints?
Yeah. I mean, thanks for the question. There's many elements to this. In terms of technological infrastructure, obviously all approaches have to be tailored to the setting. So you have to see what's available. In our pilot sites, we actually take different approaches. Connectivity can be provided by, for example, Starlinks, wherever that's available, so satellite-based internet. But most technologies also provide, or at least most dedicated technologies, or the ones we use, provides for the option to use SIM cards for connectivity. So there's different options, and you really have to make that part of your situational assessment to decide about the technology. And the other thing is, I think, very important. It is that, it's the teams that actually have to decide who is going to be the consultant, who is the expert in the setting. And I believe that while telemedicine can, in theory, connect whole regions for improvement of quality of care, it's also important to stay in the specific setting and decide who is the expert center, who is the hub for this in this country, and who are the providers that are going to be connected to this hub.
Thank you so much. So with that, I would like to thank all our speakers in our session titled Bridging Sepsis Knowledge Gaps in High-Income Countries and Low-Middle-Income Countries. We heard from Andrew Argent, Sheila Myatra, Louise Thwaites, Elanor Gomersall, Victor Akelo, and Wiltrud Abels. I would like to thank each and every one of you listening and watching us from around the world. Please visit our website, and if you haven't, please sign the World Sepsis Declaration, and you can follow us on social media. That is Facebook, Twitter or X, Instagram, LinkedIn, and TikTok. And at the end, I would like to thank our sponsors, our gold sponsors, Sanofi, our silver sponsors, bioMérieux, our bronze sponsors, 14-4, Adrenomed, and Thermo Fisher. And thank you very much, and looking forward to the next World Sepsis Congress.